Thank you so much, ma'am. You have already set the bar a bit high, saying my presentations are good. So, uh, but it was really difficult to make presentations while working with full hours and so much of workload in the office. So, but still, I tried my best, and I'll try to put some light, sharing my experiences in the department while reporting the glioblastoma cases, as well as the future and the aspects which have changed in the recent years, like from 2016 to 2022. Uh, Truly speaking, I started reporting. I came across this GBMs and all the neurotumor cases after 2016 because at that time during my training session in the neuropathology, 2015 WHO was just introduced. So I saw the transition area. I saw the transition from 2016 to 2022. Uh, it was very new for me, and gradually I have learned from all these great stalwarts in the AIMS, Dr. Vishali Puri, Dr. M. Sharma, and Dr. Chitra Prakash. I really thank them. Without wasting further time, and we will start our lecture. Yes. So, neuroepithelial tumors, as we all know, previously already discussed in the previous lectures, they are graded from grade 2 to grade 4. The grade 2 tumors are they have a very good, relatively good prognosis, and they show very less rate of recurrence. When we start seeing a bit of higher grade histological features like increased cellularity, slightly increased cellularity, slightly increased nuclear reticia, and few mitosis, then we shift to the grade 3. And ultimately, when we come across the microvascular proliferation, necrosis, and very high Ki67 index and frequent mitosis, then we call it grade 4 tumors. So, but all the grade 4 tumors, it's not only the histology now we come across, we have to see the genetic alterations as well. So gone are those days when we had to rely upon the histology alone. In fact, now the histology is inferior, or we can say that the molecular findings are superior than histopathology in many cases, where the histopathological findings are not sufficient to grade a disease, grade these gliomas. So, based on the tumor mass extension, microvascular proliferation, necrosis, and proliferation index, and the genetic alterations, we call a tumor, and we divide the tumor into grade 2 to grade 4, not just on the basis of histology. So GBMs are the grade 4. GBMs, the grade 4 tumors are the most aggressive tumors of CNS, and the genetic alterations we have come across in last 10 years, such that the GBMs are one of the best well-known tumors at the molecular level. Uh, we know the inside out of the GBMs uh, 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 at all the levels. And besides this extreme advancement in the molecular findings, still we don't have the therapeutic targets like in breast or prostate cancer where we can personalize the medicine, because GBMs are very dynamic tumors, and they are like moving targets, and we cannot target these tumors with a single chemotherapeutic agent or just simply by radiation therapy. So we will discuss them in detail further. So and also so early and extent of surgical resection remains still the key to improved outcomes. So identifying a tumor at right time and the extent of surgical resection is a very important prognosis. Shows a very good prognostication, because if we remove the tumor in early stages, we prevent the progression of a grade 2 to grade 3 or grade 4 tumor. Because a grade 2 tumor will definitely progress to grade 3 or grade 4 if it is not adequately removed. This is I am sharing the data of our hospital from August 2021 to May 2022. So, a total number of cases of adult gliomas were 92 in this approximately 1 year duration. And out of these 92 cases, 56 were GBM, and all other astros and oligodendrogliomas, excluding the grade, they were remaining were S2 and oligodendrogliomas. But if we compare the grade 4 tumors, then glioblastoma constitutes 90% of the cases. So significant or almost all the grade 4 tumors belong to this category, belong to glioblastoma. And amongst oligodendrogliomas and astrocytomas, they both have almost 50, 55 or 45% of distribution. This data of our institute corroborates with worldwide data as well. Even if we see the data of other good published articles in the international journals, the data there coincides with our data that the GBMs constitute 90% of the grade 4 tumors. So, what is important for a pathologist that the pathologist must see beyond this life. Can I remove this? I hope I'm audible to everyone.
Yes, sir.
Okay.
Yes, you are audible.
So, what pathologists should see, they not certainly just the slide, and a pathologist must go beyond the slide, like the clinical details of the patient. Age is very important factor. Generally, glioblastomas are disease of older age, like 55 plus or around 60 plus minus 5 years. But in recently, what we are seeing is a trend which is showing in younger age as well. We are coming across glioblastomas with classical features in age group of 35 or 45 as well. So currently in every organ system, age has not been a very restricted bar, and we can see tumors in different age groups as well. Location again, majority of these glioblastomas are subcortical, are located in subcortical white matter or in the deep gray matter. The onset of symptoms, generally they are acute, and 70% of cases of glioblastoma present with less than 3 months of duration of onset of symptoms and the time of diagnosis. While in grade 2 tumors like astrocytomas, they generally present the duration of onset of symptoms and diagnosis is around 8 months. So this is WHO data. Similarly, past history is also very important for glioblastoma. Generally, glioblastoma present as fresh and routine cases, and astrocytomas they generally recur, and we get to see a recurrent case in astrocytomas more frequently than glioblastoma. Glioblastomas also show recurrence, like previously operated and again coming back to the. Definitely, it happens when the surgical resection is good, and the tumor definitely comes back. If the tumor is not coming back, definitely the patient has not survived. So in glioblastomas, it means that the glioblastoma has a poorer survival, poor overall survival. That's why we are not able to see the recurrent cases. Astrocytomas, we are able to see the recurrent cases. That means that it has a better overall survival than glioblastoma. Then coming to the radiology, these days radiology is coming very close to the pathology. Our radiologist at our center, actually his experience is more than my age, and he is so good at radiological description of these gliomas. He even used to tell that this tumor should come out as IDH mutant, or this tumor should come as IDH wild type. And I'm really surprised from his observation. And sometimes he used to be my guiding light in identifying the exact grade, truly speaking. So the radiologist is a very important beam of diagnosis for these glioblastomas. So conventionally, they are irregularly shaped, ring-enhancing peripheries with central darker areas of necrosis with peritumoral edema. But sometimes glioblastomas don't show any contrast enhancement or minimal contrast enhancement, and they lack central necrosis. Even then, the radiologist can call them glioblastoma, provided they have a perfusion scan available. Like in this case, this is a T1 contrast imaging. We don't see any contrast enhancing area, but when we go in the perfusion, we see this red hot burning kind of area, So this is the high grade focus. This tumor is this kind of picture we come across in a particular variant of glioblastoma, like small cell variant of glioblastoma, which oligodendrocyte like morphology. So these
Gaurav,
kind, yes, ma'am.
speak close to the mic.
Okay, ma'am. Okay. Uh,
Yes.
so sometimes in glioblastoma we come across cases where there is no or minimal contrast enhancement, and in those cases, if there is no availability of these perfusion scans, it may be difficult for the radiologist to call the grade. And uh, uh, I'll discuss the case of in coming slides. So radiology advancement in the radiology is very important at your center to help you in the diagnosis. So first of all, I don't see the topmost heading here. So, coming to the adequacy of the tumor, which depends on the tumor location. For example, like tumors sometimes involving the motor strip are located at a very crucial site. In those cases, it becomes very difficult with the conventional techniques for the surgeon to operate that area, and in those cases, the pathologist may not get the adequate tumor tissue. But the recent advancements like use of fiducials is quite old now. And recently, many newer techniques have come for neuronavigation, or like frameless stereotactic surgery, preoperative or intraoperative functional MRI, or electrophysiological mapping of the brain area. So this leads to this specific kind of surgery helps increasing in the yield of the tumor and preventing the surrounding area. Surgical approach to the tumor is also very important, and sometimes radiologists help the surgeons to what should be the exact approach to the tumor to target the lesion. Sometimes, if a tumor which is wrongly approached, it may lead to that the tumor is left there and it is not removed in entirety. So the approach to the tumor is also very important. Then the skill of this neurosurgeon. A named neurosurgeon might use CUSA to remove that tumor, and this may lead to fragmentation of the tumor and wastage of the tumor tissue, and may not and the pathologist may not come up with the right diagnosis. So, using conventional instruments and removing the tumor in toto without disturbing the architecture should be the approach of the neurosurgeon. So these all these factors help in determining the adequacy of the tumor. So uh, what are the classic histopathological features of glioblastoma? What should be the approach to the slide? First of all, it should one should look to the cellularity of the tumor. Cellularity is the most important factor to diagnose the case. In fact, it helps in the frozen section evaluation as well. Sometimes a surgeon may not have approached the tumor center, and we might get only the periphery of the tumor tissue. So in those cases, we must ask the surgeon whether the instrument has gone into the tumor section, into the tumor area, or he is sampling the peripheral area only. So cellularity is the most important factor to determine whether the tumor tissue is going to come to us or not. In fact, cellularity, but the pitfall in cellularity comes in lymphoma. Lymphomas also show very high cellularity in frozen section evaluation. But in lymphomas, the cells will be singly scattered, they will be monomorphic, and in gliomas, there will be still some cohesion between the tumor and and the cells will be more atypical, more pleomorphic. Cells will be different size, and we will see the cytoplasmic processes while studying this layer. Lymphomas will not have any cytoplasmic extension if the slide is properly smeared. So, based on the cellularity and cell size and the cell morphology, we can quite confidently differentiate on frozen section evaluation that we are dealing with a glioma or a lymphoma. Then diffuse infiltration and poor circumscription of the tumor is another feature which is very important in all these gliomas, specifically in glioblastoma. Though there are certain tumors of glioblastoma variants which show quite well circumscription and quite well bordered, like in giant cell glioblastoma. We'll come to a case of giant cell glioblastoma. But generally, they show diffuse infiltration. Then this diffuse infiltration is also important in radiology. Like what I was telling is that the the borders of the perfusions are always more than the borders of contrast enhancement. If a surgeon approaches a tumor on the basis of contrast enhancement, he is definitely going to leave some tumor at the edges of the main tumor. And those cells which are left at the borders of the edematous area, which was not picked up in the contrast, leads to recurrence of these tumors. But the perfusions can highlight even the borders, even the border areas, the edematous areas which have thinly infiltrating tumor cells. I'll show that area in incoming slide. So a surgeon who approaches a tumor based on the perfusion can definitely have a better, definitely provide better survival for glioblastoma cases. We have seen our cases of glioblastoma which are in follow up for last 3 to 4 years, and they are doing surprisingly well, and which is very unusual for glioblastoma. The reason is nothing other than that the tumor was the extent of excision was definitely very good because it was based on the perfusion scan, and it has included the borders as well. So, uh, yes, coming to the variably differentiated cells. So, astroglial cells, which are in a glioblastoma, we see glial cells of variable differentiation. We can see very well differentiated astrocytes as well as poorly differentiated cells. Then microvascular proliferation is a hallmark, and but though we get glioblastomas, though very vascular tumors, in fact, one of the vascular tumors of the body, but still they are hypoxic. We come to the causes of hypoxia in further slide. So the microvascular proliferation, then tumor necrosis. Tumor necrosis can be palisading, or it can be zonal, or it can be geographic, and it should be differentiated from the radiation necrosis. Then how the sources of conflict arise. Sources of conflict are like inadequate tissue, like when the tumor is at a difficult location and the stereotactic biopsy has not yielded adequate sampling. Then sometimes there is sampling of non-representative area. In those cases, radiologists fight with the pathologist. Like in a case, I remember that I called my radiologist that I'm not able to see any high-grade area. So my radiologist said that there are definitely high-grade areas. You are not able. Why don't you see the high-grade areas? There are definitely high-grade areas. Then I went back and I screened my slides. My entire tumor tissue was sampled, and I screened the entire slide. Even I got the deeper section. Even then, I was not able to find any microvascular proliferation or necrotic areas. So I could label it only grade 2 tumor. But my radiologist was insisting. Then finally, I said to my radiologist that you must check the post-operative scan. Is the high-grade area was focal? Was it removed or not? Then he realized that the high-grade area which was focal in that tumor was not removed. So you may have to ask the radiologist that whether the high-grade area has been removed or not. But sometimes vice versa also happens. So, in those cases, a rider or a comment like findings are limited to the tissue submitted and radiological correlation is warranted must be there in your report. So, coming to the variable variants of glioblastoma, these are the variable morphological patterns which we come across, like dermatocytes, giant cells, epithelioid cells. Epithelioid, in fact, it's a different entity now, epithelioid glioblastoma, but still comes under glioblastoma. It's just a morphological variation, and which is showing a little bit of different genetic pattern. Then mesenchymal or gliosarcoma, then oligodendrocyte-like cells, then small cell or glioblastoma. Small cell glioblastoma or oligodendrocyte-like cells are they both coincide and they both show similar kind of morphology. Then glioblastoma with primitive neuronal components, then granular cell glioblastoma and lipidized glioblastoma. These two I have not seen yet, granular cell glioblastoma and lipidized glioblastoma, and yet to see this kind of variation. But yes, we have seen all these variants, and I will show these variants in coming cases. And distribution of these different areas is also very important. Sometimes they may be continuously or intimately mixed, but sometimes these different morphological areas are show abrupt transition. When there is abrupt transition of these two different looking areas, that suggests that there is subclonal molecular diversification. That means a different clone is arising from a tumor, and it's definitely not going to respond to a single kind of agent or single chemotherapeutic agent. So, diagnostic molecular pathology is in fact the more important field nowadays compared to histopathology. So, all the glioblastomas are IDH1 wild type, and there is, but they must, should we do IDH sequencing to confirm IDH wild type nature in every case? No, there are certain requirements. Like if we have age of more than 55 years, there is no previous history of gliomas, and the tumor is non-midline and showing retained expression of ATRX, and morphologically it is looking like glioblastoma, then there is no need to confirm IDH wild type nature by sequencing, and we can just rely upon IST only. Then the characteristic hallmark of GBM, or the most common mutations which we come across, are the third mutation, EGFR amplification, gain of chromosome 7, and loss of chromosome 10. Also, loss of chromosome 9 is also quite frequent. Chromosome 9, which is CDKN2A2B loss. So homozygous loss of CDKN2A2B, although characteristic of astrocytoma, is also seen in glioblastoma as well. Then metaplastic changes like sarcomatous or epithelial metaplasia, these again the morphological variations. Sarcomatous metaplasia can occur de novo, but it is more commonly seen in the recurrence cases. So in this, gemstocytic or astrocytic areas are alternating with spindle cell areas. These spindle cell areas are actually undifferentiated, and they are negative for GFAP and OLIV2, and they are reticulin rich compared to the astrocytic or well differentiated areas. Rarely, other mesenchymal differentiation can also be seen, like osteoid, chondroid, or micromatous, but I have never seen this kind of differentiation in glioblastoma. Yes, I have seen one case which I will discuss in pediatric gliomas. We saw myogenic rhabdoid and myogenic skeletal muscle differentiation in a case of anaplastic PSA, which transformed to GV. So that was a very beautiful case. I'll discuss that case in pediatric gliomas. Then,
I have seen in our institute at FMRI
okay,
GBM with osteogenic sarcoma
osteogenic sarcoma.
and GBM with squamous cell carcinoma.
Oh, nice,
That I have
nice.
seen
Maybe before I joined.
before you joined.
Okay. So phenotypic change with or without clonal evolution and not separate neoplasm like collision tumor. So there may be some phenotypic change without clonal evolution as well, and it may not be a separate neoplasm. That means the phenotypic, that's what I discussed in the last slide, that when there is abrupt transition, that indicates that it's a clonal evolution. It's a diversification of the molecular evolution. And but when it is intimately admixed, it may not have much significance. It's just a phenotypic variation. So, and these sarcomatous have slightly different molecular profile. They show PTEN deletion, P53 mutation, and CDKN2A deletion are common. And +7, -10, which is other glioblastomas, are common, but EGFR amplification is less common in cases of glioblastoma. Then there can be epithelial metaplasia also, which can show adenoid or squamous metaplasia. So if we compare to 2016 glioblastoma to 2022 glioblastoma, the category of IDH mutant glioblastoma is now removed, and it has been changed to IDH mutant grade 4 astrocytoma, which was 10% of cases. So now this is obsolete. Otherwise, we call it as glioblastoma IDH wild type. This remains the same, and glioblastoma NOS if we are not able to perform the molecular by for any reason, like if the test has not performed due to unavailability or due to some technical fault, then we call it as glioblastoma. And then differentiating between IDH mutant grade 4 gliomas and glioblastomas, IDH mutant grade 4 astrocytomas constitute 10% of the grade 4 adult gliomas, while glioblastomas constitute 90%. Earlier, it was also called as secondary GBM, but now it's obsolete. There is frequent 3 alteration in grade 3 and frequent CDKN2A and 2B loss in high grade astrocytomas, while in glioblastomas, the frequent molecular alterations are EGFR amplification, PTEN loss, and TERT mutation. CDKN2A 2B loss feature of grade 4 astro is also seen in GBM, but less common. The average survival of treatment after treatment is 31 months, while average survival after treatment in glioblastomas is 18 months. So, uh, so far we have learned that there are specific or signature mutations of glioblastomas like EGFR, PTEN loss, TERT mutation, +7, -10. So, the duration of these molecular changes also plays a very important role. At what step these molecular alterations are happening, like TERT mutation, which if occurs early event, which occurs early in the disease, it doesn't have a very bad prognosis, and it's like in oligodendroglioma. Oligodendroglioma, TERT mutation is an early event in tumorigenesis, and it does not lead to very harmful or very poor overall survival. While if it happens in a late stage, it leads to significant it adds to the significant morbidity or mortality or associated with the tumor. So the early stage tumor or molecular alterations are like gain of chromosome 7, which leads to EGFR amplification, or PD platelet derived growth factor A amplification. Then loss of chromosome 9, which leads to homozygous loss of CDK and 2A to B. Then loss of chromosome 10, which leads to PTEN deletion. So third promoter mutation is a late event in glioblastomas, while an early event in oligodendrogliomas, and it does not predict prognosis in oligodendrogliomas. But in glioblastoma, it's definitely a poor prognosis. EGFR amplification or mutations like point mutations or factor 8 deletion is particularly associated with the increased aggressiveness of these gliomas, even if the histology corresponds to a grade 3 tumor. So this is very important. EGFR, if we get to see a EGFR amplification in a tumor, that means that the survival is not going to be a very good, and the patient has a very poor survival. If we compare IDH mutant grade 4 astrocytomas where there is ATRX loss, we don't see TERT promoter mutation in astrocytomas because ATRX and TERT mutations are mutually exclusive, and they both lead to lengthening of the telomeres, thus promoting the immortalization of these glioma cells. So either TERT promoter mutation will happen or ATRX mutation will happen. ATRX mutation is the signature of IDH mutant astrocytomas, while TERT mutation is the signature of glioblastomas. But the function of these two mutations is similar, that they both decrease the senescence of glioma cells by lengthening the telomeres. So this is the microenvironment of the tumor. Although glioblastomas are one of the most vascular tumors of all the tumors, but still the microenvironment of the glioma has been described as hypoxic and immunosuppressive. And this hypoxia is the hypoxia inducible factor is the main driver of all these things which are happening, all these events which are happening in a glioma cell. So all these mutations which we have described so far, they all ultimately end up increasing the hypoxia inducible factor, and the hypoxia already occurring due to the tumor inefficient tumor vasculature. Although there is vasculogenesis happening, neovascularization is happening, but all those vessels are inefficient and they don't provide the adequate amount of oxygen in the tumor cells. So ultimately, the environment of a tumor milieu or milieu of the tumor is hypoxic. When this is hypoxic, this HIF1 alpha undergoes degradation by the VHL associated molecules. So prolyl hydroxylase is the enzyme which acts in a normoxic condition. That means normal oxygen concentration In the normal oxygen concentration, this prolyl hydroxylase leads to degradation of this HIF-1 alpha, and it causes instabilization of this molecule, and it undergoes proteasome-mediated degradation. But when the oxygen level falls, this molecule does not act on this, and HIF-1 alpha gets stabilized and it moves to the nucleus where it binds with the DNA and show various alterations in the glioma cell. Like it leads to reprogramming of the glucose metabolism. Like in a normal cell, which uses pyruvate to pyruvate and transforms into acetyl CoA through oxidative phosphorylation, producing 38 ATP. While in a tumor, this starts Barber's effect. This starts showing Barber's effect. That means the glucose is now producing lactate. Despite of availability of some amount of oxygen, but the tumor has shifted its metabolic reprogramming, and metabolic reprogramming has shifted its pyruvate to lactate formation. This lactate formation is again a driver of so many things that it creates an acidic milieu, and it further prevents the hypoxic environment. It further creates the hypoxic environment and acidic milieu. All these factors lead to uh, uh, increase in further HIF-1 alpha. Then it increases the autophagy of the cell. It increases the invasiveness of the tumor by altering the extracellular matrix protein. It increases the angiogenesis by producing the pro-angiogenic factors like PEGF, PDGF, and erythropoietin and angiopoietin. And it creates a immunosuppression environment of immunosuppression. Like it attracts the T2 macrophages and it attracts the myeloid-derived suppressor cells and various other cells like T-regulatory cells. All these cells are immunosuppressive. Although in glioblastomas we see very less amount of inflammatory cell infiltrate because it's a blood-brain barrier, and blood-brain barrier does not allow the inflammatory cells to come into the tumor area. But when the blood-brain barrier is leaky or weakens because of the tumor necrosis, then only the inflammatory cells can enter into the necrosis. That is why we don't see much of necrosis in glioblastomas compared to a necrosis in other areas of the tumor because of this blood-brain barrier. Then glioma cells. The glioma cells also transform into these endothelial cells. We will come in the next slide. I'll show you. So this the HIF is the main driver of this tumor, which helps in changing the which helps in promoting all these pathways, which help in the promotion of the glioma cells. So the abundant and this distinct kind of extracellular matrix in a glioma, this produces so many factors which helps in the neovascularization. This neovascularization happens by three methods. Like the pre-existing vessels start sprouting these new vascular buds, but this vascular proliferation, which leads to glomeruloid-like morphology, these vessels are very inefficient and they don't supply adequate oxygen to the tumor cells. So still the environment remains hypoxic. Then there is transmigration of bone marrow progenitor cells, endothelial progenitor cells from the marrow. These endothelial progenitor cells home these tumor cells and they start producing the new vessels. And there is some transdifferentiation as well. These glioma cells have some stem cell plasticity, and these glioma cells transform into pericytes and endothelial cells, and they start forming these vessels. Despite of this and all new vessel formation, the environment still remains hypoxic because the vascularization, these vessels are inadequate in supplying adequate oxygen. Earlier, it was postulated that there is tumor cell co-option, that the tumor cells adhere around these blood vessels. In fact, we see this kind of spread in the surrounding area, which is called as perivascular satellitosis. We see the tumor cells in the cortical parenchyma, that the tumor cells are encasing or cupping the vessels. So, but that this vascular co-option compresses the vascular lumen, and this leads to hypoxia. This is another theory or a hypothesis which, for hypoxic environment of the tumor. Maybe it's true, but it's still yet to be proven that whether the vascular co-option is the exact reason or these molecular play or molecular orchestra is leading to this vascularization. Yes, coming to the now with this all this background, I think we should come to the cases. So this is the case one. Case one is oh, I didn't mention the age of this patient. Sorry. So case one was yes, case one is 65-year male patient presented with altered sensorium with single episode of seizure. And radiologically, we can see this contrast enhancing solid cystic lesion in left frontal periventricular region. And radiologically, it was a high-grade glioma because of this contrast enhancement, peripheral ring enhancement. It's just very classical radiology as well. And the age is also quite favorable, that is 65 years. But the histology is a little bit unusual. You see these different ages. This is very cellular, quite dark blue, and the surrounding area is quite pink. And we can see this large, big atypical microtubular, and the cells here quite big and large, like looking like PXA. But this area is showing very undifferentiated area and quite abrupt in the transition. So this what we were seeing. So these Bimentin is showing patchy positivity. So these undifferentiated cells are showing synaptophysin positivity. 353 is showing mutant expression and GFAP. We can see these filamentous thread-like intermediate filaments which are labeling with GFAP, and this has patchy distribution, and the small cell component is showing less amount of GFAP expression. This this is another area. P53 is also showing mutant expression in this small cell area. Synaptophysin is negative in some areas, but Ki67 is very high in this undifferentiated area. So this is a glioblastoma which is showing uh, undifferentiated or primitive neuroectodermal differentiation, which was showing synaptophysin positive. And coming to the case two is yes, case two is 41-year male patient, and this patient was a known case of right insular glioma and was operated in 2014 and post radiotherapy, and now it was a recurrence in 2019. So we can see here that the age gap is quite big, so the patient is quite well surviving in this case. So here comes the yes. We can see that the area is this area is showing very pleomorphic cells, very large cells, this intranuclear infusions, and some of the cells are lipidized as well. So this is showing PXA-like area. And this is spindle cell type of morphology. At places, the tumor cells are appearing in the spindle-shaped vesicles as well, and some lymphocytic aggregates as well. So this looks like a PXA to me at this morphology. So here we can see this glomeruloid kind of tree-like vascular proliferation. These endothelial cells are forming palisades, or we can see that these are like overlapping cluster of endothelial cells. The tumor cells are quite bizarre looking, very spindly as well, and very epithelioid looking. Now, the transition areas, here we can see very different areas which are showing marked epithelioid kind of or rhabdoid like of morphology, and there is area which is showing tumor necrosis. So these cells are showing quite rhabdoid kind of morphology. And here we could see that these are PXA-like areas, where we saw the lipidized area, pleomorphic cells, lipidized cells, lymphomatous cells, and this perivascular lymphocytic aggregate. Then the high part of this area is showing loosely cohesive cells which are showing abundant glassy vasculated type of cytoplasm and extensively placed high-grade nuclei. But the surprise was IDH was mutant in this case, and ATRX was lost, and P53 was mutant. GFAP was showing heterogeneous kind of expression, and KH67 was very high. So this was quite unusual morphology, and I was also surprised why we are thinking. This case was in 2019. At that time, we didn't have this option, and we were still following the 2016 WHO, and we called it as glioblastoma. grade 4 IDH mutant, but actually the term should be astrocytoma grade 4 IDH mutant. But it's very unusual to see this IDH mutation in epithelioid kind of morphology. The more commonly the seen is BRAF mutation. And we have seen the cases of epithelioid glioblastomas which show BRAF V600E mutation. We'll discuss those cases as well. So but as this was unusual, it was also confirmed on molecular as well. So on sequencing also the IDH1R132X mutation was detected. This tumor was also MGMT was also mutated and 1P19.2 coordination was not there. At that time, we didn't have the third promoter mutation in EFR amplification at +7-10 in our glioma panel, and we have got this in 2022 only. So earlier we could not perform these molecular tests which are characteristic of glioblastoma now these days. Coming to the next case, yes, this is the classic case which I was talking about in the last slide. This is a 7-year male, and it was a known case of PSA. This case should have been discussed in the pediatric glioblastoma, but okay, because we are dealing with epithelial glioblastoma in adult gliomas only, so we can discuss this case here as well. So this was a left parietal lobe lesion. We can see this quite big solid cystic mass, and this highly contrast. See, this area is coinciding with this vascular perfusion. Extremely red area, and this area is corresponding with the contrast enhancing, showing significant mass effect, and it was a known case of PXA. So we can see this classical morphology of PXA, the large pleomorphic, bizarre-looking cells with some lipidized cells and spindling at the periphery of the tumor. The hyper view of these lipidized cells, pleomorphic xanthochromate cells. Then there were areas which were quite solid and sheet-like with epithelioid kind of morphology, and there was brisk mitosis. There 1, 2, and 3, and 4. 4 mitosis in a single field we can see in this area. So GFAP was patchy in distribution, and focal predominantly the sheet-like area was lacking the GFAP expression. Similarly, was a CD34 expression. CD34 was also patchy in distribution. IDH1 was wild type, and ATRX was retained. So quite classic of epithelioid glioblastoma. BRAF P600E is showing strong and diffuse positivity. P53 is showing mutant expression, and Ki67 is high. So it's a case of epithelioid glioblastoma. PNSW grade 4, IDH1 wild type, BRAF P600E mutant. So currently, the current WHO classifies epithelioid glioblastomas into 3 distinct molecular classes. One is prognostically favorable outcome, which is seen in children and young adults. This overlaps with PXA and BRAF600E mutation as well as CDKN2A2G deletion. Then epithelioid GGMs with intermediate type of prognosis. These are RK1. This is RTK1 actually. Receptor tyrosine kinase 1 type of pediatric high-grade gliomas associated with PDGFRA amplification and chromosepsis. I will come to this RTK1 type of tumor in pediatric gliomas, and we will touch this kind of description in further slides. Then the third molecular class of epithelioid GGMs is poor prognosis tumor, which are seen in adults and elderly, and it's similar prognostically as conventional glioblastomas despite of this BRAF mutation. So people may ask that how to differentiate the anaplastic PXA from epithelioid glioblastoma, although it's very difficult to differentiate these two entities, but generally anaplastic PXA definitely they proceed to epithelioid glioblastoma, and there is very thin borderline between these two entities. But yes, we can definitely differentiate to a large extent. Like epithelial glioblastomas will definitely show a higher mitotic count, and we'll see the sheet of these epithelial cells which will be missing in the anaplastic PXA. Even if it becomes anaplastic, that is, it's grade 3 tumor, but the mitotic count will not be comparable to that seen in epithelial glioblastoma. S100 will be diffuse and strongly positive in anaplastic PXA, while it will be patchy positive in epithelioid glioblastoma. CD34 we have seen in our case was patchy in distribution, or we cannot see any kind of CD34 expression. But here in anaplastic PXA, CD34 4 will be strongly positive. Similarly, will be the synaptophysin expression, it will be strongly and diffusely positive in anaplastic cases, and it will be patchy or weak positive or negative in epithelial GBMs. Necrosis will be more abundant, while anaplastic it will be lesser in content. Then KH7 will be very high, and it will be lower as compared to epithelial GBM. So it's basically you have to compare, keeping in mind that how would be the findings in epithelial glioblastoma and what we are coming across. This was an original research article which I published with the help of Dr. Vaishali Suri and Dr. M.P. Sharma on epithelial glioblastoma. There were 7 cases of epithelial glioblastoma which we studied, and we saw the most common mutation as BRAF-V600E. Uh, 3 out of 7 cases we saw BRAF-V600E mutation, and 1 case showed DIRT mutation, and 1 case showed EGFR amplification. And 1 case showed fetal deletion. So this was the genetic spectrum. So definitely, BRAF-V600E is more common in epithelial glioblastoma, but there it does not predict the prognosis. And epithelial glioblastoma still have conventional GBM-like prognosis. Earlier it was a provisional variant, but now GBM has defined it as a variant and established its entity, and they are associated with low-grade precursor, that is PX. And they are typically present as superficial cerebral or diencephalic masses. They may involve the meninges as well, because PXAs are more commonly meningocerebral in location. Coming to the case 4, uh, yes. Case 4 is 53-year male who was operated for right temporal glioma in June 2016 and now presented with recurrent seizures. And the provisional diagnosis is recurrent right frontotemporal high-grade glioma, and operative findings were tumor involving the right frontal lobe, soft grayish moderately vascular, necrotic debris and thrombosed vessels with high-grade glioma. I could not get the radiology images of this case. So the tumor is very cellular, showing round to oval kind of cell population. GFP was positive, IDH was mutant, and ATRX was lost. You can see this internal control, and this P53 is mutant, and K57 is very high. So this is not a case of glioblastoma, and it's a case of astrocytoma, CNSW grade 4 IDH1 mutant. But because it's a case of 2019, so at that time we called it as glioblastoma only. But now, if the case comes now, we will call it as astrocytoma, CNSW grade 4 IDH1 mutant. Coming to the next case, this is 33-year male patient who presented with right cerebellar glioma, which was operated in 2015, then reoperated in 2017, and then recurrent in 2019, and then 2020. So multiple times operated case in a 33-year male patient. Yes. So this is the typical palisading necrosis, and we can see this. We can see this hyalinized kind of vessel, and the tumor cells are running out of. It looks like tumor cells are running out of this area. We may say that this necrotic area is hypoxic. This is having acidic milieu, and tumor cells are running away from this hypoxic area. Definitely, these tumor cells uh, have adopted this hypoxic environment, this acidic milieu, but still the tumors don't like this kind of environment, and they start running out of this area, and they start forming these palisades. These palisades are very characteristic of this lab. So this tumor is showing this oligodendrocyte-like morphology of these cells, or you can say some clearing of the cytoplasm. Yes, GFAP is positive, IDH1 is negative, ATRX is some wrong image. P53 was wild type, ATRX was retained in this case, and this case was glioblastoma CNS grade 4, IDH1 was wild type. This image has been wrongly placed here. This image does not belong to this was retained in this place, that then only we can call it as a glioblastoma.
You know,
Coming to
ATRX staining, we described it, it as retained or lost or mosaic pattern. So
yes,
in
ma'am.
this one is mosaic pattern, which actually requires further molecular test for confirmation. But usually the mosaic pattern is indicates most often it indicates a mutant
Yes,
expression.
ma'am.
That means
This retained, definitely
lost.
retained in some of the tumor cells, and
In certain area, then lost in other areas. No, so this is a mosaic pattern.
Coming to the case 6, this is 52-year male with visual field defect with one episode of seizure, and we received a specimen which was measuring 4.3 centimeter, and it was a left occipital lobe intraaxial tumor. So here, what I was talking about, that the tumor is quite circumscribed. You can see this circumscribed area, and this is the normal looking cortical parenchyma and very sharp border. But these single tumor cells are infiltrating in this peritumoral edematous area. We can see that tumor is a bit lighter staining than this normal looking cortical parenchyma, and we can see this singly infiltrating tumor cells in this edematous area. But overall, the tumor is quite circumscribed, and we can see this serpentine kind of palisading necrotic area. So coming to the high part, so this is palisading necrosis. Tumor cells are running out of the necrotic foci, making palisade, and this area is showing. This is showing zonal necrosis. So a necrosis can be palisading necrosis, it can be zonal necrosis, or it can be geographic necrosis. Geographic necrosis are more commonly seen as a result of radiation changes, but these zonal necrosis and palisading necrosis are the features of tumor. So quite cellular, very pleomorphic looking cells, different kinds of necrotic areas. And here we see very bizarre looking pleomorphic. Definitely these cells quite mimic like those of P active, but we are not seeing here any lipidized cells or xanthochromic cells. So these cells are very bizarre. Majority of them are showing giant cell kind of morphology. So we are abundant giant cells with bizarre and pleomorphic nuclei. GFP is showing very beautiful filamentous thread-like staining. Only 2 is positive but not diffuse and strong. IDH1 is wild type and ATRX is retained. So classic IST panel for a glioblastoma. P53 is mutant and Ki57 is very high. So these are the quite characteristic feature and very characteristic case to call it as giant cell glioblastoma, which is IDH1 wild type and P53 mutant. So giant cell glioblastomas behave slightly differently from other glioblastomas because because they are quite well circumscribed, as seen in our case. So they may mimic, because of their well circumscribed borders, they sometimes mimic metastasis or meningiomas as well. Meningiomas when they are attached to the dura, and they are de novo, and they are more common in pediatric population, and they are commonly subcortical in location in parietal and temporal lobe. And giant cell change can also be seen in IDH mutant and H3 mutant gliomas. So it's not very specific, but in glioblastomas, they may have very circumscribed borders, and P53 mutation is quite characteristic of giant cell glioblastoma. Also, there can be MMR deficiency or 4E mutation in giant cell glioblastoma. Prognostically, it is slightly better than conventional glioblastoma. Coming to the next case, this is 51-year male patient presented with single episode of GPCS, and tumor was situated in temporal lobe, right temporal lobe. So temporal lobe tumor presenting with GPCS, quite common. Temporal lobe tumors present with epilepsy. But yes, this was the case. Yes, this is the lesion showing high vascularity in perfusion scan. And this is the edematous area which I wanted to show you. Like this is the tumor area beyond this is well-defined tumor. This band we can see is the edematous area, and this area is the normal cortical zone. So we can see this image in the right upper half and left upper half. This right upper half is showing edema. This left lower half is showing normal looking cortical parenchyma. but there are perineuronal and perivascular satellitosis. So tumor cells are infiltrating these 3D matrices. That's why I was stressing upon that the perfusion scan is more important. The borders of the perfusion scan are more than the contrast. So here comes the quite typical morphology, like these branching capillaries. This tumor was also, yes, this tumor was the case which was not showing very high contrast enhancement, and it's quite iso-intense expression. But on vascular scan, there were some areas which were showing high perfusion value. So this is the case which is small cell glioblastoma. We can see the cells are quite monomorphic. We can see here these mitotic figures, 1, 2, and 3 mitosis in single field, and these branching capillaries in the background. The higher part, so the cells are quite small. They are monomorphic nuclei. They are only mild kind of nuclear epithelium with delicate branching capillaries, but the mitosis is quite frequent. So all these features are very typical of this tumor. GFAP is strongly and beautifully positive in filamentous thread-like structures. This is OLIC2, which is positive, IDH1 is negative, and ATRX is retained. P53 is wild type, and Ki67 is again high. So this is the case of small cell variant of glioblastoma, which is showing monomorphic kind of cells with oligodendrocyte-like morphology, branching vessels in the background like screw paw vessels, very similar to oligodendroglioma. But definitely the cellularity is high. Ki67 is very high. IDH is a wild type. That's why we didn't call it as anaplastic oligo. We could have called it anaplastic oligo if IDH would have been mutant and ATRX also retained. So it's a glioblastoma. Coming to next case, this is 51-year female presented with left temporal SRL, query metastasis, query GBS. Yes. So we can see here, this is the cellular area, and the left half is showing this entire necrotic area and the abundant vascular proliferation. And thrombosed vessels, some of these vessels are thrombosed as well, partially canalized. So very typical of this morphology, the balloon-like cells with hyalinized kind of cytoplasm. This reminds me of in liver, the ground glass hepatocyte, very similar to ground glass hepatocyte. So these are gemistocytes, abundant globoid, pinkish, hyalinized kind of cytoplasm with eccentrically placed nuclei. We can see these branching vessels. Some of them are showing proliferation and central this kind of zonal necrosis. But here also we can appreciate some palisading of these tumors. Rim of tumor cells surrounding this necrotic area. So GFAP is showing positive in the cytoplasm. OLIC2 is positive. IDH1 is negative, and ATRX is retained. And there were areas of necrosis we saw in the first image. So this is the case of glioblastoma, which is showing gemistocytic morphology. The diagnosis remains glioblastoma only. This is just to show you the morphological variations in the glioblastoma. Gemistocytes can be seen in both glioblastomas as well as in astrocytomas. And the gemistocytic astrocytoma, when we see the IDH mutation and more than 20% of the tumor cells are showing gemistocytic morphology, then we can call it as gemistocytic. Going to the last case, this is 54-year female, previously operated case of GBM and presented with recurrence. So few days back, one of my colleagues called me up to discuss what are the radiation-induced changes and how to detect them, how to differentiate them from the true tumor necrosis. So that's why I included this case. So this radiation-induced necrosis will always show vascular changes. These hyalinized vessels or fibrinoid necrosis of these vessels and this kind of dystrophic calcification indicates that the tumor has been treated and the tumor cells are dead due to necrosis. The necrotic areas are so large that you have to hunt for the viable areas. So that gives you an indication that the tumor has been irradiated and there are radiation in it. We can see here the transition area The left upper half is showing entire necrosis with these vessels which are showing hyalinization, and the lower left half is showing spindling of these tumor cells or spindled areas which are arranged in fascicles. So this is the glioblastoma, the viable area. And here we can see this palisades or palisading arrangement of these tumor cells. And this is the viable component. So GFAP is still coming positive in these viable tumor cells. OLIC2 is also highlighting these viable tumor cells. IDH1 was negative in these areas and ATRX was retained. So P53 was mutant and Ki67 also highlighted. Not very high, but yes, because Ki67 is not very high, maybe because the mitotically active tumor cells might have become the target of the radiation. So we are not left with a very brisk mitosis. In the radiation-induced changes, this is another finding. We were not able to see the brisk mitosis as a conventional glioblastoma case because the radiation typically targets the actively dividing cells. So we were not able to see the mitosis. So this was a case of glioblastoma skinus WHO grade 4 IDH1 wild type with radiation induced. So these were the cases. Now we come to the future aspects. Although these are quite familiar as of now, and maybe in the next WHO we may see the again an entire different classification which may include methylation profiling and transcriptional profiling or transcriptome profiling. So what is DNA methylation? Methylation is an epigenetic change. That means there is capping of the DNA by methyl groups and in specific regions which alters the reading of that DNA, which alters the information hidden in the DNA, and it's different from the change in the sequencing because it does not alter the reading frame, it does not alter the reading sequence of the DNA, but only that the methyl group is added to a particular location. This leads to DNA methylation. So there are also other epigenetic changes like histone modification. Um, these are the two most common epigenetic changes like DNA methylation and histone modification. So the epigenetic change acquired somatically during tumor progression. This facilitates the tumor classification in different cancers. It's a robust and reproducible technique, but still there is limited knowledge and it's a slow and costly process. So based on this DNA methylation, IDH wild type tumors and IDH mutant gliomas are divided into three groups. All these three groups have similar clinical behavior regardless of the epigenetic differences. So one group is RTK1, which is enriched in PDGFR-A amplification. RTK2 group, which show high frequency of gain of chromosome 7 and loss of 10, including the EGFR amplification. Then the mesenchymal tumors, which show methylation profile almost similar to the normal brain tissues despite of substantial copy number changes. Then coming to the IDH mutant gliomas, that is astrocytomas, they also are divided into three DNA methylation clusters, which are 1p19 to co-deleted cluster. This show elevated methylation. This is called as LEM3. Then there is glioma CPG island methylator phenotype high. So these are non-co-deleted clusters. Then there is one newly described cluster which is uh, glioma CPG island methylator phenotype low cluster. This shows reduced methylation. This is associated with poorer survival when we compare to these two other groups. So this is a DNA methylation clustering of IDH wild type and IDH mutant gliomas. This is not being included as of now in the WHO, but maybe in future we may come across this kind of classification, which will include both the methylation profiling and transcription profiling. So this is transcriptome profiling. Transcriptome is basically the sequence of mRNA. So based on mRNA, what kind of proteins are synthesized by the glioma cells? We are dividing the gliomas into four types. Like one is classic. These tumors, the gliomas which fall in this category, they show high rate of cell division, and they are by some authors they are also known as proliferative classes. They show EGFR gene amplification with loss of P10 and CDKN two-way copy. While P53, NF1, PDGFRA, and IDH1 genes are almost absent. So The classic glioblastoma cases fall under this heading. There are some response to radiotherapy and chemotherapy, probably due to high dose of chemotherapy, high dose of chemotherapy, probably due to activation of the wild type P53 function. Because the P53 is still wild type, so it may lead to apoptosis of the tumor cells. So there may be some response to radiotherapy. And they are also sensitive to MDM2 inhibitors and negative regulators of P53. Then comes the mesenchymal type. This also overlaps with classic subtype, but it shows P53 mutation, NF1 gene alteration, and P10 deletion. These are the most frequent type of genetic alterations seen in the mesenchymal type. This is also relatively responsive to intensive treatment with temozolomide, but a little bit of high resistance to radiotherapy because P53 is mutant here. And they are sensitive to RAS and PI3 kinase inhibitors as well, and anti-angiogenic molecules as well. So a broad spectrum of chemotherapy has to be used in these gliomas because we don't see a single molecular pattern in these in the glioblastomas. There are always a spectrum of genetic changes in the glioblastoma. And in fact, the mutations are evolving. And glioblastomas are not static, they are evolving tumors. Then coming to the pro-neural classification, pro-neural group, they have relatively better prognosis compared to the other groups because they have the IDH1 mutant tumors. They are in younger patients. Expression profile is reminiscent of neuronal development, and they show high expression of known oligodendrocytic and neural markers. They overexpress PDGFRA. P53 can also be mutant, and they show PIK3CA and PIK3R1. And the significant accumulation of +7 and -10, which is more frequent in the classical subtype, may also be seen, but it's less common than seen in the classical subtype. They are highly invasive and they are less sensitive to radiotherapy and chemotherapy, maybe due to the epigenetic upregulation of the TMA response in the presence of IDH1 mutation. Then the neural types, they are most similar to the normal brain tissue, and the increased expression of the neuronal markers. Some people even believe that the neural markers do not belong to any specific subtypes of gliomas because there are no definite pattern of mutations and they are very similar to the normal brain tissue. So they might be the areas which have been extracted from the areas surrounding the main tumor. So and they were not able to characterize these tumors. So based on methylation profiling and transcriptome profiling, this is the individual tumor cell mapping showing the distribution of the tumor cells, the pro-neuronal, which are showing IDH mutation, P53 mutation, and the classical subtypes, which are the classical glioblastomas showing EGFR amplification, PTEN loss, and PDKN2A2 loss. This is the group which is classical, and the green one is pro-neuronal. And these are the mesenchymal which are widely distributed. So, summing up, based on the molecular clustering, they facilitate the accurate prediction of the response of gliomas to inhibitors of these specific pathways, and we may allocate the patients into different clinical trials. GBMs are highly heterogeneous disease. We have seen that there are different type of molecular alterations which are going within the same tumor and within the different cells. Even the different cells are showing different types of mutations. So there is diverse transcriptional programming going on in the tumor. There are different clones in one single tumor which leads to different drug sensitivity. In fact, the methylation subtyping seems to be more consistent during the tumor progression. So transcriptome profiling keeps on changing, while the methylation subtyping, which involves the RTK1, RTK2, the metabolic programs, they remain relatively same while the tumor is progressing. In fact, this needs further studies and more refined and robust profiling to classify these glioblastomas into this molecular classification. And definitely a combination of transcriptional, epigenetic, and genomic data, especially at the single cell level, will offer the best classification of gliomas and may predict and may show better predictive value. So, treating a GBM with a single chemotherapeutic agent is like hitting a moving target with a single bullet. So definitely we are not able to, we will never be able to hit the target uh, uh, sharply or exactly. So we need to use the pellet gun in fact to kill this glioblastoma, which means that we should include the combinatorial approaches targeting different subclones and as well as their supportive microenvironment. We have seen the supportive microenvironment, the hypoxia-inducible factor, the role of hypoxia-inducible factor, the role of extracellular matrix proteins, and the factors which were released by extracellular matrix. So they should be the target. So everyone, I recommend these articles to go through. These articles are very helpful to build up a kind of base or understanding of these glioblastomas. And I acknowledge my thanks. I extend my thanks to Dr. Sunita who has given me this opportunity, to Dr. Rakesh Gupta sir, who is our radiologist, a great person, and our great, very well equipped and very well talented, a very senior team of neurosurgeons, Dr. Rana Patel, Dr. Sandeep Vaishya, and my thanks to Dr. Utkarsh Bhagat who helped me in the clinical aspect of these lab. Thank you so much.